Hello, dear students of Jabir bin Hayyan Medical University, Faculty of Medicine, the fifth stage, Department of Pediatrics, is greeting you and wishing you and your families to be in good health. Please protect it from the infection with coronavirus. Your lives is very important. These are a series of lectures of the gastroenterology, and I will start with the first lecture that is about the disorders of esophagus. I hope you will find the benefit from the presentation of this lecture by this way. And thanks in advance. Firstly, we will know the outlines and the major topics of this lecture. Introduction, definition of gastroesophageal reflux and gastroesophageal reflux disease, pathophysiology, clinical manifestations, diagnosis, and finally management. First, we will take a few notes about the anatomy, embryology, and physiology of esophagus. By definition, esophagus is a muscular tube that connects the pharynx to the stomach. Embryologically, it is originated or developed from the foregut, and it is recognizable at the 3rd week of gestation. The length of esophagus at birth varies from 8 to 10 cm, and by the age of 15 years, the esophagus reaches the length of 19 cm, but in adults it's about 25 cm. The esophagus is a muscular tube, as we say, and it has two sphincters, upper and lower. The beginning of esophagus on the upper end is from the lower border of the cricoid cartilage of the larynx, and this is correspond to the body of the 6th cervical vertebra. It extends downward behind the trachea and the heart and passing through the diaphragm to reach the cardiac orifice of the stomach, and this is correspond to the body of the 11th vertebra. This is in the adult. But in newborn infant, it is started from the 5th cervical vertebra and reach to the end at the level of the 9th thoracic vertebra. As we say, the muscular tube of esophagus has two sphincters, the upper called the pharyngeocricoid or cricopharyngeal sphincter, and the lower is the gastroesophageal sphincter. These both sphincters are muscular rings. The innervation of the smooth muscle of the wall of esophagus is by two ways: sympathetic through the sympathetic trunk and parasympathetic through the vagus nerve. The main function of the esophagus is for the delivery of food and the fluid from the mouth to the stomach through the peristaltic movement of the muscular wall of it. This is a cross section in the wall of the esophagus, starting from mucosa to the adventitia. The mucosa is of 3 layers, and it is of the stratified squamous epithelium. And the muscles are smooth muscles and of straight type. The swallowing function of the esophagus started from the pharynx and passed downward. So the swallowing reflex begins at the 16th week of gestation, while the suckling or sucking reflex starts at the 2nd to 3rd trimester and at 34 week of gestation if infant born prematurely can suckle and feed normally, but before this gestational age the process will be incoordinated because the swallowing is developed or begins earlier, while the suckling will be later. So this incoordination causes major difficulties, starting from feeding difficulties, or it may be to serious conditions like the choking and suffocation and even aspiration. The pharyngeal face of the swallowing process started earlier, while the oral preparatory phase maldeveloped in premature infants, as we said. Now the gastroesophageal reflux and the gastroesophageal reflux disease, or what we called GERD. First, we have to know these definitions. The first is regurgitation or spitting up. It is a effortless movement of the stomach contents into the esophagus and mouth. The regurgitation is normal in infant, and it is a major complaint we can see in medical practice, especially in pediatrics, but it is normal, so that's why I put in green. While the vomiting is the expulsion of the reflux gastric contents from the mouth, and it is not normal. It could be pathologic, benign causes, or other. Now, what is gastroesophageal reflux? It is the passage of gastric contents into the esophagus with or without regurgitation or vomiting. Or in other words, it is a retrograde movement of the gastric content through the lower esophageal sphincter into the esophagus. So, if it is accompanied with vomiting or regurgitation, it will be outside of the mouth, but sometimes it may reach to the level of esophagus, then disappear. So, what is GERD or gastroesophageal reflux disease? The same gastroesophageal reflux, when causing troublesome symptoms and or complications of persistent type of it will lead to gastroesophageal reflux disease. Or in other words, we can define it in this way. It is gastroesophageal reflux that's become pathological when it causes troublesome symptoms and physical complications. So this picture shows the retrograde movement of the gastric content through the lower esophageal sphincter to the esophagus. If it ended with regurgitation or vomiting, or it may stay here at the esophagus. So what happens when highly acidic contents of the stomach are refluxed back to the esophagus? Of course, it will irritate and sometimes damage the mucosal surface of the esophagus because of the difference between the lining of epithelial cell. We say the stomach is of simple columnar, can resist the high acidity of the stomach, while in the esophagus it is of stratified squamous epithelium. So, gastroesophageal reflux disease is a clinical condition that is severe enough to impact the patient's life and or causing local damage to the esophagus and its complication. Now, we will know the mechanisms which prevent the gastroesophageal reflux. As shown in this picture, we can call these mechanisms as anti-reflux barrier. Firstly is the tonic activity of the lower esophageal sphincter here, and you can see the difference between lining of esophagus and the stomach at this level of meeting of the esophagus and the cardiac orifice of the stomach. So this is the first barrier. The second is the valve-like mechanism of short portion of esophagus that passes through the diaphragm. I mean here. Can act like a valve. And the third is the fibers of a crural portion of the diaphragm that surround the esophagus also will act as a valve and prevent the reflux. Now, what are the mechanisms of the gastroesophageal reflux? Or, in other words, why it happened? Yes, it is a normal physiologic process and can be seen in healthy infant and children and even adult. But why it happened? Here you can see the difference between the esophagus of the infant and the adult. Of course, it is of short length and of limited volume. So first is the transient relaxation of the lower esophageal sphincter. And the second mechanism is short infant esophagus and limited volume. And of course, the babies and infants predominantly in recumbent position or lying flat and supine. And there will be delayed emptying of the stomach and increased abdominal pressure. While in adult, here is the gravity that has the action to prevent the regurgitation or the vomiting and decrease the likelihood of the gastroesophageal reflux. This picture shows the difference between the normal lower esophageal sphincter that is closed completely against the gastric content, and in cases of the relaxed lower esophageal sphincter permit the passage of the gastric content through it into the esophagus, causing the symptoms of the gastroesophageal reflux. Now, what is the pathophysiology of gastroesophageal reflux? Firstly, we have to know that a well-coordinated relaxation of the lower esophageal sphincter is very essential for the transport of food in the stomach. And we have the basal lower esophageal sphincter pressure, which should be maintained above 4 mercury millimeter to prevent the reflux. So the main stimulus for the gastroesophageal reflux is the gastric distension. And this has come from overfeeding, overweight, and increased abdominal pressure. So if this happened, this will lead to increase the transient lower esophageal sphincter relaxation that occur independently of the swallowing, and the pressure will reduce to be less than 4 mercury millimeter, between 0 to 2 mercury millimeter, and the time it will be more than 10 seconds. So this is vagally mediated and causing these abnormal urinary control of the lower esophageal sphincter. This will lead to increase in the gastroesophageal reflux. This is regarded as internal causes, and the external causes or additive causes like hiatal hernia or obtuse angle of His could lead to more increase in the gastroesophageal reflux. So remember, the main stimulus is the gastric distension, then the transient lower esophageal sphincter relaxation, making the tone in it is less than 4 millimeter, between 0 to 2, and the duration is more than 10 seconds and occur independently of the swallowing. Then, if these symptoms will persist and causing what's called troublesome symptoms or complication, this will lead to gastroesophageal reflux. And of course, there will be impaired pH neutralization due to the difference between the acidity of the stomach and the esophagus, and delayed acidic clearance with poor mucosal resistance. So we clarify the gastroesophageal reflux can be classified into two: physiological, one, and pathologic or symptomatic. That's called the gastroesophageal reflux disease, which may be due to primary causes due to motility problems affecting lower esophageal sphincter, or secondary causes like external factors causing transient relaxation of the lower esophageal sphincter. An example of this is food allergy. Now, what are the natural causes of the gastroesophageal reflux? This will differ according to the age group. So in an infant, the reflux become evidence at the first few months of life, and at 4 months of life it peaks in about 65% of cases, and in 12 months of age it resolves up to 88% of cases. And at the age of 24 months, it resolves nearly all. In premature baby, the high incidence of the gastroesophageal reflux disease, it may reach to 85%. And 10% of them, they have extra-intestinal manifestations like bradycardia and apnea, while in term babies, the prevalence of gastroesophageal reflux disease is about 1 to 8%. In older children, it tends to be chronic, waxing and waning symptoms, relapsing and remission, going and back. 50% of them completely resolves, and 50% of them resemble the adult pattern of gastroesophageal reflux. Now, what are the conditions with higher prevalence? In other words, it means the high risk to develop gastroesophageal reflux disease. Cerebral palsy, and of course, this is because of the neuronal impairment that affect the vagal innervation of the lower esophageal sphincter, causing decrease of the tone, and of course the babies with CP always recombinant, and this will lead to reflux of the and retrograde movement of the gastric content. Hiatal hernia and repaired tracheoesophageal fistula as external causes leading to more reflux. Obesity causing gastric distension. Genetic predisposition, so the gastroesophageal reflux disease runs in families and the preterm infants. And the pathophysiology, and that's why the high prevalence of the gastroesophageal reflux is not well understood in premature infants. Now we will talk about the presenting symptoms and signs of the gastroesophageal reflux disease. And also this is different according to the age of affection. So in infant there will be feeding refusal, recurrent vomiting, poor weight gain, irritability, arching or head tilting or what's called pseudotorticollis, gastrointestinal bleeding, upper or lower respiratory associated symptoms, and apnea or ALT, which is acute life-threatening events. While in preschool age, the manifestations will be like intermittent vomiting or regurgitation, less commonly respiratory complications such as persistent wheezing or decreased food intake. It may cause poor weight gain without any other complaints and may be a symptom of esophagitis. In older children and adolescents, there will be heartburn, chronic cough. These manifestations like the adult pattern of the gastroesophageal reflux disease, and there may be regurgitation, nausea and epigastric pain, or esophagitis, and sometimes maybe extraintestinal and respiratory complications or manifestations like asthma, recurrent pneumonia, and hoarseness of voice. Now, what are the complications of the gastroesophageal reflux disease? We have local complications or esophageal complications, and we have extra-intestinal complication. So the local is erosive esophagitis due to damage of the mucosa, such rupture as a chronic inflammatory process and fibrosis. Barrett esophagus, which is a condition of metaplasia. The squamous epithelium become transported or changed to be like the epithelium of the stomach, which is simple columnar. Weight loss and failure to thrive is both recognized as complication for gastroesophageal reflux disease. Adenoidal enlargement and otitis media, dental erosion, asthma, progressive pulmonary fibrosis, and adenocarcinoma. These are extraintestinal or sometimes called supraesophageal manifestations and complications. Now the diagnosis of the gastroesophageal reflux and gastroesophageal reflux disease. The first step of diagnosis, as usual, is by the history and physical examination. So taking a proper history and performing a good physical examination, it may be essential and sufficient to reliably diagnose the gastroesophageal reflux and recognize complications and initiate management. So what are the questions that should be concerned in the history? We will focus on the feeding history, and questions should be about the amount and frequency, because it may be due to overfeeding causing gastric distension, which is the main stimulus for the gastroesophageal reflux. We have to ask about the type of feeding, whether it is breastfeeding or artificial or mixed, because if it is artificial, there may be preparation errors. And we should ask about the technique of feeding. This means the positioning of baby during and after feeding, and if they do purging for him or not. The pattern of vomiting is very important. So ask about the frequency and the amount of the feeding of the vomiting, and in the preschool age children or school age and adolescent, you should ask if it is painful or not because of the forceful vomiting. And you have to ask about the past medical history of prematurity, because now we know the high prevalence of the gastroesophageal reflux disease in premature babies, and ask about the growth and developments, because it could impact the growth and development, causing delayed milestone, or the patient may have difficulty in the milestones or in the retardation of the growth because of conditions like CP. Surgery is very important to ask in the past medical history, because the patient may have hiatal hernia or repaired tracheoesophageal fistula. The psychosocial history also is very important. Ask about the citrus as a predisposing cause. And in family history, which is very important, to ask about significant illness in the family and if there is GI problems similar to this or not, and ask about the history of metabolic and allergic disorders. Then we will go to do the growth charts. Take the growth charts and taking the growth parameters, length, weight, and head circumference. These are very important in most infants with vomiting and most older children with regurgitation and heartburn. The history and physical examination alone should be helpful and differentiated between infants with benign, recurrent vomiting, like physiologic gastroesophageal reflux, from those with have red flag signs of the gastroesophageal reflux disease or other underlying causes of primary conditions that may present with recurrent emesis at this age. So what are these red flag signs or warning signs? Bilious emesis, GI bleeding, onset of vomiting after 6 months of age. In the natural course, it is become evident for the gastroesophageal reflux, at the first few months of life, and it peak in about 65% of the cases at 4 months of age. So if they start after 6 months, this may be for a warning sign for a cause that is not benign and serious cause. Failure to thrive and diarrhea is also warning signs, and it causes dehydration. Fever and lethargy, hepatosplenomegaly, abdominal tenderness or distension, and neurologic changes and seizure due to electrolyte disturbances or due to CP. Macro or microcephaly, also an important warning signs. Now, after finishing or completing the history and physical examination, we will head toward the investigations. And the investigation will be Firstly, upper GI series and barium study. This should be considered just when the anatomic etiologies of recurrent vomiting are considered, but should not be considered to be a test for gastroesophageal reflux disease per se. Anatomical difficulties like, as we say, hiatal hernia or tracheoesophageal fistula. So this picture shows the X-ray of the 65-day-old neonate, showing or demonstrating significant gastroesophageal reflux in association with sliding hiatal hernia. The second is trial of acid suppressant therapy. This is considered as both diagnostic and therapeutic in older children with heartburn or frequent regurgitation. So giving the patient antacid and see the response. The third is esophagoscopy and mucosal biopsy. And these are useful for evaluation of the mucosal injury secondary to the gastroesophageal reflux. You remember the complication like Barrett esophagus, stricture, or erosive esophagitis. And also it is important to evaluate for non-reflux diagnosis that present with reflux symptom, including eosinophilic esophagitis. Now this picture shows the normal esophagoscopy as an A slide and pathologic from B to E, whether the mucosal damage or stricture or erosion. And the final tool of investigation is assessing and monitoring the esophageal pH. You know, the normal acidity of the esophagus is maintained above 5 if it is for the upper portion of the esophagus, and for the distal portion it should be maintained above 4. While the acidity of the stomach, it is between 1.5 to 3.5. So assessing the acidity, and if it is less than 4, it is indicate the presence of acid reflux, and it is enough for diagnosis of gastroesophageal reflux. Gastroesophageal reflux disease can be diagnosed by pH monitoring, which is the most quantitative and the sensitive method, and it assesses not just the presence of the disease but the efficacy of the treatment. So look at this young infant, and this device is for monitoring of the pH of the esophagus. This can be recorded for about 24 hours. How they do it? Insert the tube through the nose to the stomach. This tube has 2 probes for assessing the acidity, one at the level of the upper esophageal sphincter and the other at the level which is above the lower esophageal sphincter. This process is non-invasive, or the least invasive one, to diagnose the gastroesophageal reflux disease, and it can be done at any age group, as you see in this picture. Now, what about the management of the gastroesophageal reflux disease? Firstly, we have to know the aims of the management. The goals of the management is to eliminate symptoms, heal the esophageal mucosa, and prevent relapse and manage or prevent the complications. The management of the GERD, it will follow the steps of the management from the most simple to the most serious according to the status and the condition of the patient, like this pyramid. So we will start from the base up to the top. The first step should be done, and if there is no response, we can go to the second step. So firstly is to make changes in the lifestyle. How we can make it? by changing the positioning of the baby, keeping the baby upright after meal. This is very important. We say one of the mechanisms that make the gastroesophageal reflux more evident in the infant is the predominant recumbent position. So putting the baby in upright position after meal, and after finishing that, you should put the head of the baby elevated more than the rest of the body in about 30 degrees, and should be on the left lateral position to prevent aspiration if there is regurgitation happen in this manner. And we can put the awake baby in a prone position. So these pictures show for the prone baby who is awake after finishing the feeding, and this is for the sleepy baby. Here is about 30 degrees. The head is more than the rest of the body. Why we should put the baby that is sleepy on the back? Because this prevents the sudden infant death syndrome, which may be happen during putting the baby on his prone position while he is sleepy. If the lifestyle changes didn't make the difference or get the benefit, we will start to make a dietary changes. How we can manage the dietary changes? This is by offering the small feedings at frequent intervals to prevent the gastric distension and prevent the overfeeding in each nursing. Thickening feeding with rice cereals, and may use pre-thickened or anti-reflux formula. This is a special medical formula for those on the medical formula, and this is contains starch. So after the milk enter the stomach, it will make a plug, which is a thick plug that prevent the gastric content from the retrograde movement to the esophagus. And if the age of the baby is appropriate to start complementary feeding, so we should introduce solid or semi-solid food, and this should be after the age of 6 months. There is a special formula also called the hypoallergenic formula, can be considered for 2 to 4 week trial if get response from. Of course, for the older children, the dietary management will change, because we should avoid the large meals, especially prior to exercise, again to prevent the gastric distension, and no eat or drink 2 hours prior to bedtime. And if obese babies, we should initiate the weight loss program and limit the food and the drink that provoke the symptoms of GERD. This picture shows the anti-reflux formula, which is a medical formula, contain starch with the milk. Now, if there is no response from the dietary management, we can head up to the pharmacology and pharmacotherapy. It's mean use a drug management. So pharmacotherapy, the aim is to give an acid suppression therapy to treat the suspected esophageal or extraesophageal complications of acid reflux in infant and older children. And in this step of management, we will follow the style of the pyramid. So we will start with the simple pharmacotherapy, and if there is no response, we will upgrade to the more potent. So firstly, we'll start with antacid for short-term symptomatic relief, like Gaviscon or aluminum hydroxide. And if there is no response, we can give histamine 2 receptor antagonists like cimetidine, nizatidine, famotidine, or ranitidine. These have a selective inhibition of the histamine receptors on the parietal cell of the stomach and this should be taken 30 minutes before the meal. But the problem with these medications, there's what's called the tachyphylaxis or diminution of response after long-term use. This means with a long-term use, the efficacy of these drugs will be lost. So if there is no response on them, we will head to the more potent part of the pharmacotherapy, which is the proton pump inhibitors, like the omeprazole, lansoprazole, or esomeprazole and pantoprazole. These medications have significantly healed the both esophageal mucosal injury and alleviate or relieve the symptoms of the GERD, but to take the time of 8 to 12 week period to get the response. And it is usually beneficial for the complication or inadequate response by histamine receptor antagonist. So for uncomplicated cases of GERD, the response may be achieved by the histamine receptor antagonist, but if there is no response, we can give, in complicated cases, the proton pump inhibitors. The important thing here that the proton pump inhibitors is not approved to give in the infants. You hear about the prokinetic agents, medications like prochlorperazine, metoclopramide, and motilium that increase the gastric emptying rate and act centrally. In pediatric GERD, there is no rule for treatment with this type of medication. Now the last step of medication, which is the top of the pyramid, is the surgery. But before reaching to this, and as we are in the level of complicated gastroesophageal reflux disease, so we have not just give the medication that alleviate the symptoms and heal the mucosal injuries, but we have to manage the complication. So what are the complications of the gastroesophageal reflux? You know the local, like erosive esophagitis or stricture or Barrett's esophagus. But the extraintestinal, like the apnea and the bradycardia, wheezing and asthma, chronic cough, chronic sore throat, dental erosions, hoarseness of voice, and otitis media. All these called the supraesophageal manifestations of the GERD. And this should be managed accordingly. We have what's called the ALTE, which is the acute life-threatening events, like apnea, color changes, cyanosis or pallor, choking, and gagging. They found that 60 to 70% of infants with ALT have recurrent regurgitation and abnormal esophageal pH. What this mean? Mean the high association between the GERD and the ALT. And the usual manifestation and the usual history is you have an infant who is awake, supine, and fed within past hour, then develop obstructive or mixed apnea. So you have to think about gastroesophageal reflux disease. I will repeat. If you have an infant with obstructive or mixed apnea, and they have the history of he was awake and supine and fed within past hour, you have to think of the gastroesophageal reflux disease. Aspiration syndrome that may happen due to the gastroesophageal reflux disease in the cases of the extraintestinal manifestations. The aspirated gastric content because aspiration pneumonia and complicated by pleural effusion, and the acidic content will cause acid aspiration of the pneumonitis, and if chronic cases and long-standing and recurrent aspiration will lead to interstitial lung disease and pulmonary fibrosis. Now we are in the top. of the pyramid, which is the surgery. We have what's called the anti-reflux surgery or Nissen fundoplication, and this is maybe considered in a child with GERD. What are the indications of the surgery? First, fails medical therapy, dependent on persistent aggressive medical therapy like proton pump inhibitors, or management for the extra-intestinal manifestations like in the recurrent pneumonia and aspiration, or wheezing and asthma and chronic cough. Non-adherent to medical therapy, poor compliance for the treatment, or persistent severe respiratory complications of GERD or other life-threatening complications of GERD. All these are indication to perform the surgery, and this can be done by taking the fundal part of the stomach and make tightening of the lower esophageal sphincter. In this way, this will relieve the symptoms and make the time for the healing of the mucosal injury, and of course this will lead to decrease of the extra intestinal or respiratory complications and manifestations of the disease. Now we are reaching to the end of the lecture. I hope it was beneficial to you, and thank you very much.